once again, welcome to another episode of Accreditation TV. Um, this is actually one day before the first anniversary of our original A360 recording that we did back July of 2025. It's hard to believe it's been a year, but we appreciate so much how many people have stuck with us throughout the year. It's been amazing. We've been just thrilled beyond measure that you've stuck with us, and whether you watched them live, like the people here now, or the folks that have tuned in, watched them later, and continue to watch even the ones that we recorded months back. So thank you so much for that. We're just excited. We're going to keep going. Have no end in sight. In fact, we might even pick up the cadence a little bit here and talk about some other things. I got some ideas I want to do. So anyway, without any further ado, I would like to introduce our two guests, and then I'll talk a little bit about CECs and that sort of stuff because I always forget to do that. But actually, neither one of you guys really need introductions. But we've got Rebecca with us, Marone, from one of our nurses, but she's also our infection prevention expert, which today's topic is going to be all about hand hygiene, which obviously is pretty important to IP. And Skip Smith, who's been around quite a bit, done quite a few of these, and then it's one of our physical environment specialists. So thank you both for joining us. Give us some time to talk about this. It's a really important topic, frankly, probably, if not one of the most important topics. It's kind of hard to believe that here we are. I don't know how many years I've been doing this, quite a few, and we're still talking about hand hygiene because I can recall doing it for many, many, many years. I was thinking about it when we were kind of getting set up for this thing. I don't want to ask you guys this question because I wonder if y'all do it too. Like whenever I'm in a bathroom, I watch people washing their hands, and I try to guess whether they've ever had a bloodborne pathogens training class by the way if they grab a towel and turn the sink off, or if they turn the sink off and then grab the towels. Anybody else do that, or is it just me?
Yeah, I just think Mary had a little dam and see who finishes first.
So yeah, I mean anyway, so well, welcome both of you. Kind of just to frame this up, right? I mean, we're still talking. So we still have a significant problem with infections, hospital-acquired infections, well, infections in general. But since we predominantly work with the hospitals, acute care facilities, or ambulatory care facilities, we'll talk about it in those terms. But we still obviously have a huge problem with hospital-acquired infections. Still focused predominantly on a handful of infections that seem to be really problematic. And I certainly don't profess to be an expert in any of those, but I do know that the data that I'm seeing anyway suggests that we still have a problem with hand hygiene, and it's kind of specific to some certain groups of people in the hospital. I'll just leave it at that. And that those hospitals that excel and do really, really well with it have significantly lower rates, which equate to significantly lower cost and significantly lower lengths of stay. So, with that being said, of course, we're here to talk about accreditation, but let's talk a little bit first about just infection prevention in general and how hygiene fits in, how not hygiene, hand hygiene fits into that. Rebecca, I'll just let you take it.
Well, it's the single most important practice to prevent any type of infection across any organization, whether you're in healthcare, food service, industry, facilities, work, anything, anywhere you go, anything you do. As you were talking about, are you watching people wash their hands in bathrooms, right? No matter where you are, it is the number one way to stop the spread of germs. It is also one of the most common findings that we have on our surveys. So, as easy as it may seem to do, it's not always done effectively or efficiently, and it becomes a problem. And to your point, Steve, this is where we get those hospital associated infections or hospital acquired infections. And we can prevent that, and we can save money, and we can do the right thing. And, it's one of the first things most employees are taught when they enter a healthcare organization. But I think a lot of times it's taught once and then it's often forgotten. So, how do we act to hold the gains and continue to teach and make sure people are doing the right thing all the time? So, I read somewhere recently that up to 100,000 deaths a year are associated to hospital-acquired infections and the lack of hand hygiene specifically. That's a pretty
Wow.
staggering number.
Yeah.
And so, we have the opportunity to do more, to do better, and keep it on our radar.
Yeah, absolutely. I mean, when you those numbers are inconceivable, frankly. Um, so Skip, I'm sorry, I didn't mean to interrupt.
Yeah, and no problem at all. But building on just what Rebecca was saying is the inconsistency and the fact that we train it once and we expect it to stick. First off, we're all adults. That's not how adults learn. We need to be trained over and over and over again. But the thing that I think I see a lot in working in hospitals right now, and it's especially when we do surveys, is the inconsistency on how it's applied. So if the policy is we're going to use a hand sanitizer every time we go in and come out of a room, that's everybody. That's not just the clinicians. And you can be on tours and I'll ask, it's like, what's your policy? What do you do? And then watch the inconsistency throughout the day for different people who might be joining the team and so on. So it's not just clinical, it's not just doctors, it's everybody in the hospital needs to be following their policies consistently, including when you're doing surveys, since we talk about accreditation, you need
Yeah.
to tell the surveyor, this is our policy, this is what we do, and this is what our expectation is, and call them out on it if they're not doing it.
You would hope it would be instinctive for anybody that's doing surveys in the hospital to, anytime they get even close to a patient care environment, to wash in and out. But um, I don't know I know I've never really observed with any, with the idea that I wanted to measure it. So, but now I'm going to for
Yeah,
sure.
and the thing that, kinda catches your attention is that, there's times where, I'll purposely start to walk into a room and
Eh,
see what they're gonna do. And
Yeah.
it's like the teams that are really good at it, they'll stop you. It's like, you need to use the hand sanitizer before you go in the room. Others that are more cavalier, you can pretty much expect that they're cavalier throughout their organization and how they approach it.
Yeah, I mean, and that's the scary part, right? And what's interesting, and then, like I said, did a little bit of research before I jumped in this, and what I found was that the majority of hand hygiene happens when the people are leaving a patient room, not coming in. And so it's not both times. It should be, frankly, both times. Perhaps they wash their hands before they enter the room, or they hand sanitize before they enter the room, or whatever. Um, but I thought that was pretty interesting that that number was as different as at least what was predicted. Who really knows? And that's a good question for Rebecca. I mean, what's the expectation? Let's just take it from the accreditation perspective that the surveyors have, and how hospitals would measure hand hygiene compliance.
So it can be a number of different ways. And, let's start with the risk assessment. Where are our opportunities based on what you find in the organization? What your policies say to that? Are you doing a secret shopper program? Are you at least measuring entering and exiting the room as you've discussed? That's often what I have found and seen put into place. However, are we looking at staff in the hallways changing their gloves every time their hands are visibly soiled? What are they using to clean their hands? Is that appropriate for, the alcohol-based hand rubs, or should they be using soap and water? So it's
Yeah.
kind of a multifaceted approach. And, every organization has its culture. Every organization has their specialties that they, um, you know, exceed or excel in. So, what suits the organization best? Some people are fortunate enough to have an electronic system hooked up to their badges. So, every time they touch a device, it does a recording. So, the data is kind of collected for them. Is that a perfect system? Not always. It's extremely expensive, but it does the work for the organization that gives them data in a real time manner. Where other organizations, they have people physically out there in the environment watching, counting, looking at the missed opportunities, recording those, and then sending a report up daily, weekly, monthly, so they can continue to work that cycle to make improvements. And a lot of times it's focused on that, like I said before, the entering and exiting of the rooms. But where else are those opportunities? ORs may have a different methodology that they're using because they have to scrub before procedures. And is that
Right.
happening correctly? So it's not a one size fits all, but at the same time, maybe it is. It needs to happen. It needs to happen at the right time, the right moment, and it needs to be consistent. And keeping that education and training going so people do the right thing.
So that risk assessment, which should be something documented and potentially shared.
Absolutely.
Yeah.
And it also should be part of the organization's goals. So, it's a big focus. Most organizations, regulatory organizations, this is a focus for them through CMS, whether it's Joint Commission, DMV, they're going to be looking for some type of a hand hygiene program. And the best way to do that is make it part of the organizational goals and try and meet it and keep improving and not going from 0 to 100. You may need to go from 0 to 30%. Hopefully you're going a little higher than that, but my point is you're going to make baby steps. You're not going to take the big leap to get to the top right away. You need to make those incremental changes and hardwire that until you make the next step and celebrate those small changes.
I
You know,
was about to say the celebration's a big part of that, right? I
like,
say, hey, look what we've achieved. Now let's go to the next level. Yeah.
correct.
Right. And that's like critically important. I think it's one of I mentioned teach it once and then never again. I mean, I literally had a bloodborne pathogens class my first week in healthcare, and that was probably had I not started hanging out with a bunch of infection preventionists at APIC and teaching for AHA, I probably would have forgotten everything about hand hygiene because it was a long time ago. I won't say how many years ago because it'll make me feel even older than I feel right now. But it was a long time ago. And so that's one of the things I think, we if I were surveying the hospital and today as a physical environment surveyor, one of the things I'd be looking for is not the clinical people hand hygiene, but what about the facilities people? What about the construction folks that are working in and out of our facilities? What about of course EVS is a whole different thing, but all of those different disciplines, how do they deal with it? And what are they taught? And what are the expectations? Like, do we expect a contractor that's working in the environment to understand this? I mean, I would want them to if they were anywhere near patient care. And
100%.
they shouldn't be that close, but still, if they are, they should be very aware.
Well, but to your point, sometimes they have to go into a patient room and do an immediate fix of a problem. So
Sure.
absolutely they should know what the expectations are and demonstrate it, on all sides of that coin to make sure they're doing hand hygiene appropriately.
Yeah.
For sure.
And Steve, the thing I would add is that, this goes all the way back to when you're planning the unit, when whatever the unit that may be, whether it's a behavioral unit, it's going to be a surgical center, it's a med surge, whatever it's going to be. In the initial PICRA, ICRA safety risk assessment process, before you start building the sticks to have a space, this needs to be assessed and really worked through. And one of the things that I think a lot of facility folks wrestle with is the clinical team has a process. Every unit has a way of doing their business. A med surg unit is not necessarily a med surg unit. They're constructed differently. It's different cultures. It's a lot of variability, and so we need to consider how do they work and allowing for the flow so that the hand hygiene is a part of that discussion as we build that environment. The number of times that we will build an environment and then we spend the next 2 years remodeling it because it didn't work, because we put things in the wrong location. And how many
Yeah.
times we to go into a patient room or in the corridor where we've got hand sanitizers and that's just the convenient place to park something else. And so they're obstructed. So you're moving stuff out of the way. So we need to make
Crap.
it accessible at the same time.
Yeah, you bring up a great point there, Skip, because you're right. When you design the environment for, let's say, a nursing care unit, you can't put a sink everywhere for somebody to wash their hands. So you're relying on the alcohol based hand sanitizer. And then you get into how much can we have on the unit, depending whether it's a
Oh, you
suite,
guys,
so you don't have too much for a fire risk, which I'm not the expert in that, and you you can address that maybe later. But it's a balancing act. You have to have it readily available at the right space, the right, you know, easy to access. But you cannot get into a fire safety issue with too much of that alcohol based sanitizer so that we now have another issue at hand. So I can't speak to those numbers of how much you're allowed. It may not be important for this discussion, but it is something to consider if you are designing a new unit. So nurses don't want to go looking for hand sanitizers or sinks. We have to know where they are. They have to be right there. If we get dirty hands because we're working with a patient, we have got to be able to access a sink without going through multiple doors to get to it. So in patient rooms, usually we can at least get to the bathroom. Sometimes there's a sink at the entranceway. It all depends. But then, just the generic, we need to clean our hands in and out. We need that hand sanitizer there too.
yeah. So I mean, it's one of the things that we were talking about with, or I was thinking about, Skip was talking about building the environment, doing the functional risk assessment, thinking about it in advance. I was, I guess because I'm so involved with rural health now, and I live in an area that's dominated by rural health. And I'm thinking about a lot of these buildings that were built during Halliburton, that they've had some modifications, but there's limitations on what we can do, and how do we help? What would the advice be to folks like that have, kind of these structural and design limitations, um, to help them build, programs that will function for them?
Well, I'm going to give you an example. I work for an organization when we build a new tower in the hospital. We were constructing during a drought. And the city came along and said, you cannot put all these sinks in because we do not have enough water to supply the hospital with all those sinks. So we didn't get them. And years went by and our water situation got better and they were able to come back and add those sinks. So sometimes you have to do what you have to do with the minimum resources you had, and then you can revisit it later to make it better so that there's more availability for hand hygiene. So it is a dilemma. And, I can imagine different parts of the country struggle with this at times. But again, you have to do what you have to do. When you have water shutoffs for construction on units, if you're doing something in place, what are you doing to mitigate that risk? Are you bringing in portable water stations so the nurses and others can wash their hands while they're taking care of patients. And again, living through construction on a unit where they shut the water down at night, you have to plan accordingly and make sure you have enough stations and make sure they're refilled in the middle of the night so that everyone can wash their hands in a convenient place.
When I used to teach all the time, for AHA, I used to talk about, again, got to get to somewhere in the space program or aviation in here. So I was talking about the Frank Borman story after Apollo 1 fire, where he was testifying before Congress and they asked him what caused the fire. And he said, a failure of imagination, right? And then he went on to explain, and he said, well, we always knew there was going to be this possibility of a fire, but we never thought it could happen on the pad, on the ground. If we had, we would have taken precautions, right? I'm paraphrasing, but that's, his point from that was, we just did not think of it happening that way. And I would tell a story. I used to have work with this one infection preventionist that would always kind of, I used to say she had Chicken Little syndrome, because whenever I would show up at the hospital, she would pull me aside and just like unload all the bad things she thought was going on that the facilities guys were ignoring, because I was kind of her advocate. And it got to the point, it was kind of like, wah, 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 wah. I mean, no offense, Rebecca, but it kind of got to that point. And I one day I kind of had the epiphany. It's like, hey, if this means so much to her, I should at least listen and really listen. And it was a transformative part of my career, I think, because I realized, even though she was concerned about certain things. I could help alleviate. Together, our two heads together were far better than either alone. And that's going to be true, I think, in any organization.
You bring up a good point, Steve, because many times there can be difficult relationships between infection control and other departments because perhaps they're supposed to have the same shared mental model, but they don't necessarily agree on how to manage that. And infection control is trying to prevent the spread of infections and germs. And facilities in particular is just trying to get the job done very often. And not that they don't care, but they're working on deadlines with a budget, time, costs money, supplies cost money, and the two have to come together and meet and make it be the most effective meeting possible and do all the right things. And sometimes doing all the right things is
Yeah.
very costly and time consuming, but it is worth it in the end to take those extra steps. And I think we've come a long way from many years ago. When infection control was really trying to, cross from just the clinical world into all sections of organizations, it was a very, very difficult challenge, and sometimes it still is. But I think, with the advent of a great ICRA tools and more education amongst facilities and organizations coming to a common ground with goals around infection control measures, I think, and we have seen some very, very bad outcomes due to some environmental concerns, not just related to hand hygiene, but other issues. I think the aha moments have occurred and we're getting better and better every day.
Yeah. And I think too, we've moved away from layering things on. So facilities needs to do something and then infection control layers something on top of it. And then we're doing something else and now we layer something else. We've really moved to an environment where it needs to be integrated. We make it a part of our work processes so that everybody has a good feel for how are they going to do this work. The IP professional can say, okay, we've talked through this, I've witnessed it, we've surveyed it, and so on. They do this as a part of their work rather than going in and going, oh, you got to do this
Mhm.
on top of
Yeah.
it kind of
So
thing.
thinking about it from the survey perspective, you're getting ready for a survey. What would the recommendation be to, the quality directors out there and how to prepare your team, both from the clinical side and the physical environment side, to, one, to care enough. That sounds horrible, but I mean, to make it a part of their habits to do good, proper, consistent hand hygiene, and also to be articulate about the importance of it if they happen to be one of the lucky ones that gets grabbed on the hallway and asked to talk about it. And whoever wants to jump in first, Rebecca.
I would say first you we've got to engage the staff. We need to educate the staff. We need to execute our plan and we need to evaluate it. So it's a cyclical process. We also need
PDCA.
exactly. With that said, as an adult learner, don't give me something to read all the time. I am not going to retain it. I need to make it tactile. I need to make it memorable so it sticks. And so I need something hands on. And there are lots of tools and games out there, if you will, that help people do better with hand hygiene. And it's when I was teaching, one of the things I would teach was applying appropriate PPE and doing a hand hygiene exercise with paint, having everybody close their eyes with paint on their hands. They get a dollop of paint in the center of their glove, and they have to pretend they're washing their hands with the paint. And then after they get done singing happy birthday out loud and open up their eyes, they reveal their hands and they can see how good of a job they actually did. Did they miss the space between their thumbs? Did they
Ooh.
miss the back of their hands? You get the tips of their fingers. You get the point. Then comes the challenge of taking off the PPE. And did they remove it appropriately so that paint didn't touch their actual skin?
Ooh,
So
that's a great thing.
so it's actually left so if you're somebody who didn't clean your hands well and you didn't completely cover your gloves in the paint, and or the paint touched your skin, now we know, it sticks. And if you're watching somebody else do it, you're like, "Ooh, I'm glad I'm not, I'm glad I did a good job." So
Yeah.
I do think that hands-on approach just sends volumes. You can do this with images if you have to do it across organizations where you can't do it in person. You can do it with picture images and do kind of like an I spy, what's wrong with this picture, and see if people can figure it out. Sometimes on the way to the cafeteria, you're able to do something in real time and catch people on the fly real quickly. So the more you can do it, that it's a hands-on, tactile type of a program, the better you're going to get the stick, and more likely you're going to get people to execute it very well. And you should see
Yeah,
it in your numbers.
I'm pretty sure I'm not right in the head because every time you mention stick and hands-on for hand hygiene, I wanted to crack up because or what we're talking about. So anyway, Skip, I'm sure you had some ideas too.
Well, actually, yes, I have ideas and things, but I wanted to add
Okay.
something to what Rebecca said, and we've said it earlier on. Celebrate it. Too often when we're getting ready for survey, it's like, well, we did this wrong, we did that wrong. It's like there's so many things that are being right. Call them out. Make it a point that people know we're being successful, and people want to glom onto that. They want to be a part of that, not the fact that we're struggling and trying to get there. So celebrate every
Yeah,
opportunity you get. Um, Going back to, kind of the technical aspects of it, the storage is certainly something that they're going to look at. If you've got more than 5 gallons being stored, do you have it stored appropriately? Um, in the hallways, less than 48 inches apart when you have hygiene dispensers. You have less than 10 gallons actively in the corridors and the open spaces. Those are the kinds of things that the surveyor is going to look
yeah, and
at.
the
They're easy.
adjacency to ignition
They're
sources.
rarely do you have a problem with that. But you're talking about earlier when preparing to have this discussion, I came across something as I was going through NFPA 101 that alcohol, when you're changing out the dispensers, that you put a new cartridge in there, there's a requirement that those are tested when the new cartridge goes in, according to your manufacturer's recommendation. And I know I've never been asked that question, but as we start moving more and more to, being outcome based, are we doing all the things that are appropriate? What are our KPIs, so on and so forth? That is a legitimate question to ask. Are they being tested? And so I just thought that was kind of an aha moment for me. It's like, didn't know to even
Yeah,
think
there might
about
be a
that
couple
one.
hundred people asking that question soon.
Well, the other
But
thing is when you're refilling your stations, whether it's soap or your alcohol-based sanitizer, you don't wanna top them off. It's a new canister every time because they do have expiration dates, and surveyors are gonna look for that, and they're gonna wanna make sure that you aren't refilling. I think that's you know, years ago, especially during COVID, we had that issue. I'm hoping that's gone away by now. I haven't seen any signs of it, but, you know, some
so
organizations
Yeah.
have difficulty getting
Yeah.
supplies.
is that something we ought to think about adding to some room checklist kind of things as expiration dates? It's easy for me to say specifically for the hand hygiene, the the alcohol-based sanitizer because can be the easiest one to check, I assume. Um,
Mhm,
'Cause I never thought about that to be honest with you.
mhm.
Um,
Yep.
but I know that stuff evaporates. So interesting. I never thought about that. See, you
Well
learn something new every day.
well, I've had, an infection preventionist or, one of our doctors say, "It's alcohol. Alcohol doesn't ever expire. It's gonna evaporate." But manufacturers have put expiration dates on the canisters, and so therefore it does need to be checked.
Yeah. And we can get into a whole bunch of discussion about where those dates come from and why, but we won't go there today,
Mhm.
for sure.
Well, it's
So,
definitely low-lying fruit, right? Anybody and who's working can check those dates and make sure. And it's usually Joint Commissions here or DMVs here running, people run and check certain things, and somebody's usually or often assigned expiration dates on those hand sanitizers.
so
Yeah.
is it safe to assume or to state that if you're some of the key indicators that you're reporting to CMS, what you're going to be reporting, or those main handful of infections that everybody's reporting on, that you should be ready to report compliance for hand hygiene, because that's, as you started this conversation, that's the single biggest factor in this equation.
Absolutely.
So,
Absolutely.
so if you're
Yep.
not doing that now, you need to probably start.
Absolutely, yes. And I would venture to say anybody who is a Leapfrog hospital submitting data, they're already doing this because they require so much data every reporting cycle. And it's a pretty decent amount depending on the size of your organization
Awesome.
on how you do
So,
that.
yeah, I mean, it makes perfect I mean, it should be something that, frankly, leadership ought to have some visibility of. I mean, not necessarily down to the individuals, but certainly what is the compliance rate? How much are we measuring? How often are we measuring? What is the numerator? What's the denominator? What's our compliance? And how does that compare to our peers? Assuming that data is available as well, because I think that's the kind of thing that leadership can impact. And certainly leaders of the organization need to be leading the way when it comes to hand hygiene. They shouldn't walk into a patient room or into a clinical area without demonstrating that.
Well, and as you're surveying, you can go the path of, all right, if I'm looking at the hospital acquired infections first, and I see that they're significantly high or higher than they should be, I'm going to look towards that hand hygiene program and see what's going on if I didn't start with the hand hygiene program first to see how those numbers look. So there's
Uh,
probably a correlation. If one's off, the other one's probably off.
yeah,
Maybe
good
not,
point.
but could very well be. At least that's in my mindset how I'm going to look at it. So it really needs to be an organizational goal. It's the single most effective thing everyone can do, no matter what your job is in your organization, whether you're a clinical staff member, a provider, dietary, housekeeping facilities, a volunteer, even your visitors. You should have some kind of signage up so your visitors also clean their hands. And even your patients. Patients need to clean their hands too. We don't want them
Yeah,
eating with dirty hands. We don't want them using the restroom and not washing their hands. It really needs to be taught on many, many levels and practiced on many, many levels.
absolutely. I mean, yeah. I mean, habits are hard to break, though, right? So, I mean, if you've got a bad habit around hand hygiene, you really have to be intentional, intentional about changing that. Man, I'm just had a stroke or something in the middle of this thing. I don't know what's going on, but I'm not very articulate today. But I mean, you have to be intentional about changing habits, or else they're never really going to change. I remember years ago, my dad was in the hospital before he passed away. We took him to the emergency room. He was in a lot of pain, and there was an older male nurse that gave him a shot of morphine. Right, and he watched him draw it, give him the shot. Well, the first thing he did is put the cap in his mouth. Gave the shot. Then he pulled the syringe out, took the cap out of his mouth, and I'm like, and he puts the cap on the needle and he throws it in the sharps container. And I was like, hey, what's your, process here for policy about, recapping needles? And he's, oh, we hadn't recapped needles in years. We never do that. And I'm like, look in the box. And he was like, did I do that? And I'm like, yeah, I couldn't stop. Yeah, I couldn't speak, you know? Um, so, I mean, it just proves the point. It's like when these things that you are kind of foundational, you start out, and if you have bad habits to begin with, it's really difficult to turn them into good habits. I mean, that's true for everything. But
You got me with the cap in the mouth.
so, Yeah. So I saw that recently too, by the way, but I won't say where. Anyway, awesome. Anything else you guys want to talk about? This, we pretty much covered it, but um, either
No, I'm good. I actually learned a
I
couple of
always
things
learn
today,
something
so I'm
from
good.
Rebecca and from you, Skip. So it's always a good time. But
Just, again, work the 4 E's: engage, educate, execute, and evaluate. And that, throw that PDCA cycle in there and you'll have a stellar program. But if people know they're being watched, of course they're going to clean their hands. So, there's a lot of subjectivity to that when people know they're being watched to clean their hands for data purposes. So,
yeah,
it's not just one number. Looking at your product use and how much you're ordering and frequency, there's a lot of good programs out there. Tap into one of them or two of them, develop that program and be consistent. And that way you'll have a robust program. You'll be able to really show your data off and show the great improvements you made because of your good hand hygiene program, as far as your hospital acquired infections, at least.
awesome. Well, that's a great way to kind of wrap this thing up. I appreciate your time. Appreciate everybody joining and watching. And of course, those are going to watch it after the fact. Again, thank you for sticking with us for this whole year. We're excited to keep it going. We'll keep plugging away in 2026 and 2027. I forgot to do this. I always do this in the beginning. Forget to mention that if you are here for the CDCs, you're part of our MSL Ready Now community. Jump over there. We'll get them for you. It's probably a little late to point out the fact that if you wanted to ask questions, you could do that in the Q&A section. But if you have questions, we'll be happy to answer those through email. And Rebecca, Skip, thank you both for your time as always and your expertise. As we already stated, we all learned something. So we'll see you all in a couple of weeks. Thank you for joining us today.
Thank you for having us.
Thank you, everybody.